Good morning. It's a pleasure to be here today. I'm Allison Sekuler, and I'm going to be talking to you today about enabling the better provision of care for people with dementia. And I want to start by explaining a little bit about where I'm coming from. I work at a place called Baycrest Seniors Care, which is all things aging. Baycrest's vision is to create a world in which every older adult enjoys a life of purpose, inspiration, and fulfillment. And really what Baycrest Seniors Care is an amalgamation of a number of different interconnected entities. So all focused on aging in one way or another. So we have Baycrest Hospital, which is a geriatric continuing care hospital, which also has, in addition to 300 beds, it has another 1,500 people coming in every single day for our rehabilitation services and memory clinic and geriatric dentistry, ophthalmology, et cetera, et cetera. We have a nursing home. It's one of the largest long-term care centers in Canada with almost 500 beds. And again, it has a real focus on dementia care and provides long-term care for medically complex patients and residents. We also have independent supportive living, assisted living, and memory care. And these are for people who have some memory issues or some other mobility issues, but don't need full-time care that you would need in a long-term care home or a nursing home. But there's still access 24/7 to medical staff, for example. And finally, we also have independent seniors living, which are for people who are older adults who can live on their own, but still want to have access to some of Baycrest services. So we have the full suite of independent living and assisted living, long-term care, and hospital. And we also have quite a lot of work going on in education and training at Baycrest, as well as in research. And the education and research units together comprise the Baycrest Academy, and that's one of the areas that I lead. And the Baycrest Rotman Research Institute is the research component of the Academy. And we work in the areas shown here: cognitive and sensory neuroscience, aging and brain health, Alzheimer's and related dementias, neuroinformatics and computational neuroscience, and translational research. And we also, by combining information across all of those different organizations and elements of Baycrest, we move from foundational science into clinical applications, into innovation, and then it asks more questions. It's this cycle of having this completely inclusive ecosystem within the Baycrest environment that allows us to maintain such excellence so that we can now be ranked in the top 5% of all Canadian healthcare organizations for performance and among the leaders in the entire country for aging-related organizations. And we're also the #1 most research-intensive hospital in Canada, with over $900,000 spent per year from each researcher. As you can imagine, given Baycrest's excellence in aging, we are asked quite a lot for our advice around the world. And fortunately, we've created a new company called Baycrest Global Solutions, which provides quality consulting and development and partnership with markets around the world. And the last thing I just want to mention, because this is where I'm going to spend most of my time today, is focusing on the other element of Baycrest that I run, which is the Center for Aging and Brain Health Innovation. And this is a solution accelerator aimed at improving the lives of older adults in Canada and around the world. And our mission really is to do whatever we can to get the best solutions into the hands of the people who need them so that they can live their best lives. So we accelerate the development, validation, commercialization, dissemination, and adoption of innovative products and services and best practices, however we can, to support brain health and aging. And we're working in these 5 purpose-driven focus areas: aging at home, caregiver support, care coordination and navigation, cognitive and mental health, and financial health and wellness. And CABI's way of working is to span the entire innovation value chain. We go all the way from when people are designing and developing ideas through validating and refining MVPs, all the way through implementing and scaling. And we work with a very broad community of innovation, so we have even greater impact. And over the last 7 years, we've invested about $140 million directly towards advancing healthcare innovations. And the companies we work with have gone on to secure well over $500 million in follow-on investments. And we've launched 359 different projects, and 130 of those have been introduced into the care system in a very significant way. So there's been quite a lot of impact to date. And one of the reasons we're seeing so much impact, I think, is because we're really focusing in this area of dementia. And why do we focus on dementia? In Canada alone, over 700,000 Canadians currently live with dementia, and that's expected to double within the next 10 years. And of course, worldwide, the number is much, much larger. And it's growing even faster now because of COVID. So there were direct effects of COVID on the brain. This is some of the work that we do in my lab. But there's also indirect effects of COVID on the brain. So all of the kinds of things we did to keep people safe, have them stay at home, have them isolate, also made it harder for them to engage in activities that would reduce their risk of developing dementia. So we know that if you can sleep well, if you eat well, if you exercise, if you're engaging in social activities, challenging yourself cognitively, reducing your stress, getting checkups for things, like diabetes and heart disease to stay healthy. If you're doing all of those things, you can reduce your risk of dementia. But the necessary sort of precautions that we took to keep ourselves safe from COVID made it harder for us to protect ourselves from dementia in that indirect way, because we couldn't eat as well, we couldn't sleep as well, and so on. So we had both from COVID direct and indirect effects, which we think are going to actually end up increasing even further the extent to which we see dementia in the broader community. Already, even before COVID, the cost for direct care of Canadian dementia patients was about $10 billion. When you combine the direct and indirect costs, it was exceeding $30 billion, and worldwide, that's in the trillions. So this is a very, very significant issue, and it's growing really rapidly. And what that suggests to us is that we need a new approach to work with dementia patients. We are seeing quite a lot of different kinds of innovations coming in, and remote, virtual, mobile, AI-powered solutions, virtual reality solutions. These are all more important than ever. And one of the things that's sort of beneficial, if there is anything beneficial from COVID, which was discussed yesterday in another session, is the impact of COVID on the uptake of these kinds of solutions. What we've seen is that people have been more open to adopting some new solutions because they had to during the time of COVID. And I think the other thing that really was hit home during COVID is that we shouldn't just focus on the treatment and care. We have to have more of an emphasis also on detection. How do we detect dementia as early as possible so that we can put the right interventions in place? And how do we prevent it from happening in the first place? That's really the best solution to dementia, is to prevent it from happening in the first place. So I'll focus first a little bit on some of these sorts of solutions that we've seen for treatment and care, and what we can do to enable better treatment and care for individuals who are living with dementia. And increasingly, what we're seeing is that people do not want to be living in long-term care homes or nursing homes. They want to age, even if they've got dementia, in their own homes for as long as possible. And so one of the innovations that CABI helped to support that came out of Baycrest is called Baycrest at Home. And basically what Baycrest at Home does is it takes all of the kinds of ideas about how Baycrest has services and supports people locally and on site, and tries to bring it into people's homes. One of my colleagues, Ron Riesenbach, said it's trying to turn Baycrest from a noun into a verb. So it's bringing Baycrest into the community. And in the services that they have, it's sort of two different kinds of categories. One is support for caregivers, and one is activities for older adults. So they recognize you need both of these kinds of things to be able to support people living at home when they do have dementia. And among the different kinds of programming that we have, it's 30 hours of live programming every week from the Baycrest at Home team. Here you see Patty leading a chair exercise program for people with dementia living at home, and their caregivers often take part in this as well. There are a whole range of different other activities. Some are, as I said, live, some are recorded, arts activities, social interactions, chats, social groups, and so on. And then there's also quite a lot of information for caregivers. There are caregiver support groups and training sessions. And one of the things that's really interesting is that we can also now use remote video connections to the home to do assessments of how safe the home is for the person who's living with dementia. So in this case, you can have an occupational therapist who's an expert in geriatrics and dementia take a virtual tour of the home and advise the caregiver how different elements of the rooms should be arranged, or where to have the person's bed. So it can make sure that the house is safer, even if Baycrest can't be there in person to do this. So we're seeing through the virtual and these remote sorts of technologies a real advantage for people who want to try to live at home in the comfort of their home, even if they're living with dementia. Obviously, a really important element for having somebody be able to stay at home is to have the right kind of training. And I know there's other sessions on training, but I do want to mention that this is one of the sorts of solutions we've supported through CABI. It's called Trualta, and it's a way of providing caregivers who are taking care of people at home training in a remote way. And when people have gone through this Trualta training program, the people they care for can stay living at home on average almost 2 years longer than they could when people haven't been trained. So the training, we really shouldn't underestimate the importance of not just the environment, but the training of the caregivers. And of course, now with virtual care becoming more and more common, we can address at least some of the sorts of issues that people may be facing even if they're living at home with dementia. So what's shown here is the traditional system where you've got the doctor and the patient working together in person. And in the middle, what you'll see is Baycrest's Dr. Morris Friedman, who we have nicknamed the virtual dementia whisperer, because he is able to basically virtually work with people who have very, very severe dementia and all sorts of behavioral problems, which normally would require them to be moved into a long-term care home or a nursing home facility. And Dr. Friedman is able to, through the virtual care program that he's developed, treat people even with very, very serious behavioral issues. Sometimes it's worked even better than it did in person, which is phenomenal. So there's the novel virtual behavioral medicine program, and Dr. Friedman and his colleagues are also doing quite a lot of work using artificial intelligence to be able to triage patients and clients to see who does need to come in to see people in person or to have other assessments or to be moved into long-term care. Now, if you are moving into long-term care or you are changing the way that your house is laid out, or you're moving into a seniors assisted living facility, it would be really nice if you had a preview of what that space would look like, because you could see what it will work best for you as. And this is an example of another kind of technology. This is a virtual reality simulation created by a company called Silico Labs. And what they've done is to create a way of designing without any programming, just sort of point and click. You can create any kind of environment and then virtually move through it so that you can experience what it would be like. And we really think that, although it hasn't yet been used in this way, it's starting to be used in real estate to show people what houses might look like, but it also can be used, for example, in transitioning somebody from their home in the community into long-term care homes, or to try out different kind of long-term care homes to see what's going to be the best fit for you. So we think there's quite a lot of opportunity in helping people live with dementia better by giving them this kind of previewed look of what their new environment might look like. And of course, once they arrive at a new environment, if it's in long-term care in particular, you want to do whatever you can to make people as comfortable as possible and stay as connected as possible. One of the things during COVID was that when we weren't able to have in-person visits, we created many, many ways of having virtual visits or e-visits. You can see here on the left a whole army, if you will, of virtual visit T-carts, we call them, where we could have people, whether they were local or around the world, they could be interacting with individuals. And even though this is not necessarily needed anymore, we hope that it will stay because it does increase engagement. The other kind of change in engagement that we saw was we used to, before COVID, have pet visits, and we knew that pets were really important in keeping people happy. And we've moved much more toward robots in this case now. So shown on the top on the right is a long-term care home that I visited when I was in Japan last time, just before the pandemic. And there were robots everywhere. Some of them like Paro, very, very expensive, or others like the dog, artificial intelligence enabled. The one you can see on the bottom is actually in our CABI space. And you can see this is, again, pre-pandemic. A woman who lived in our long-term care center would come down every day to play with this Joy for All cat. And we ended up during pandemic giving her her own cat because she couldn't come down and visit us anymore. And she would be completely stoic, and then she would pick up the cat and a huge smile would come on her face and she'd just come to life. So whatever we can do to bring joy into people's lives, that's really what our aim is. The other way that we can bring joy into people's lives is by keeping them engaged. And in this case, again, there are lots of solutions. This is Mind VR, where you can have people engaged through virtual reality. So you can, in this case, play with a virtual cat, or you could visit anywhere in the world. And this is another way that you can visit different places in the world with a solution called MotiView out of Norway. And what MotiView does is it allows people to reminisce about places that they've been in the past while they're cycling. And so it keeps you engaged in exercise while you're engaged also in the virtual visual information. And so you have this sort of this double whammy of cognitive and sensory and kinesthetic engagement. And again, it does wonders for people in terms of helping them maintain their memories through reminiscence. And also, we know that exercise is quite good for the brain as well. So this is a combined interaction. And of course, the more we can do to personalize engagement, the better. So not everyone will want to ride a bike. Not everybody will want to use virtual reality. Different people like different things. And so WellBe is one of the solutions we've been working with to help personalize that engagement and for people to keep track of what will work for individuals. And this can be used in long-term care. It can be used at home. It can be used in seniors assisted living. But it's really wonderful for people with dementia in particular because they can't always convey to you what their needs and wants are. And so WellBe is one way of having a system that tells you what's most likely to work. And that personalized approach is really, really critical for us. And at Baycrest, what we've done, and again, with support from the research and education group collaborating with the clinical group, we've developed a new model of care called Possibilities. And Possibilities, as I said, really focuses on the individual and the fact that even if someone's living with dementia, it doesn't mean their life is over. They still have more of their journey to take, and they want to do it in a way that they can live with possibility and purpose. And we've got a number of different principles honoring the whole person, and it's also very much based in science. And so the science from the research institute that I run is fed directly into the Possibilities framework so that individuals can have the most up-to-date information guiding them in their care. And of course, there's quite a lot of technology that's built into the Possibilities areas, including some of the ones that you saw before, virtual reality and engagement tools, as well as tools that will help you avoid falls. And I know there's another session on that, so I'll just mention Safely You is one of the companies we work with, which can help significantly reduce falls and also help you avoid them in the future by showing you what led to a fall. The training is a really important element of any of these kinds of systems because you've got a new approach to long-term care in this case, or seniors care. And so you need to be able to train people. And in this case, the Possibilities team has created all kinds of tools, and they've collaborated with our education and research and CABI teams to be able to create a personalized training program built on this, this LIFA program, which we co-developed for training people to do work in long-term care, nurses and personal support workers and so on. And we can personalize this for different kinds of systems like the Possibilities model. Another kind of training that's really important is developing empathy and understanding. And in this case, I'm showing an example from Carrie Shaw's company, Embodied Labs. And this is a virtual environment where you live as though someone you're seeing what somebody who has a certain disorder might have. In this case, it's showing macular degeneration, so the individual cannot see where they're looking. And by living that experience, you gain more empathy for the individual as a caregiver. And finally, I want to stress the importance of making sure that we're supporting not just the individuals living with dementia, but also the care workers. We need to give them as much support as possible. And this is a mental health support system that we've supported, X2AI Test, which is a mental health chatbot. And increasingly, we're going to see more and more of these kinds of supports. We also want to make sure that we're addressing issues of detection and prevention. And this is where you guys are going to have to cut this part out because I went way too long. Let me just get to the back here. So in all of these cases, whether we're trying to create innovations for prevention, detection, care, treatment, innovation is the key to enable better provision of dementia care. And we also believe that end user engagement is key to enable innovation. And at CABI, we've recently created a new platform called LEAP, which puts older adults and caregivers at the center of innovation. And we invite you to visit that and learn more about what we can do when we work together to ensure that all people can live longer, live better, and live more. Thank you.
Thank you, Allison, for your presentation, and thank you for. I think that has inspired a lot in the local workers. We have received some questions from the audience, and it would be great if you can answer some of them. The first question is the Baycrest using own technology devices or buying from the market? For buying from outside, do Baycrest got designated staff or team in selecting and accommodating use of the tech in service setting?
So we actually, thank you first of all for having me, and it's great to be here. And I heard that the first day of the conference went wonderfully well, so hopefully today will go equally well. So in terms of where the solutions come from, many of the solutions that Baycrest buys, and this is true for long-term care and seniors care organizations across Canada, are from external providers, but then they need to be adapted for the particular use within that context. So one of the things actually that we're quite advanced at Baycrest is both for ourselves and helping other groups figure out how do you adapt, take an off-the-shelf product and make sure that it's going to work in your setting, because each different organization has different workflow issues, different kinds of patients, different sorts of layouts. And so it's not really a one size fits all, even if it's off the shelf. So we do tend to take a lot of commercially available kinds of products and the products that we support through CABI. It helps us stay at the leading edge of what's being developed so we can try them out. And while we're sort of helping the companies develop them to make sure that they'll fit our needs as well as others. And then there are others that we do develop ourselves as well. So Cognicity is one example of a company that actually came out of the research that what goes on in the Research Institute at Baycrest and now is available for other people. So it's really a mixture, but even something off the shelf still needs to be adapted a little bit usually.
Oh, that's wonderful. Then that will take education and also learning process for all the workers as well. So thank you. And also the other question will be, what is the sector's norms of tech use at care setting? Is the Baycrest the only forerunner now? And what is the tech adoption in general in Canada for now?
So I think the question is how well are different organizations adopting different kinds of technologies? Yeah, it really varies from institution to institution. Baycrest has the advantage of being the largest long-term care home in the country. And, we also have quite a strong foundation that raises money for us so we can try out new things. And then we're also the home for CABI, so we have the ability of having early access. But we do partner with quite a number of other organizations across Canada and internationally as well. So we've done trials, for example, of the LEQ robot from Intuition Robotics, which is something that helps people sort of age on their own at home. We tested that out both at Baycrest and in San Francisco at a sister hospital there. So we have partners around the world. We've tested, and we're working in the next few years to be able to build that even more. We would love to have more test sites in Asia, as well as across Europe, Israel, and other places too. So, and we also can take devices from any of those places and test them in Canada. So people who have solutions and are looking to get into the North American market, where it's really a great place to come to Canada because it's relatively small compared to the States. But because CABI works so closely and Baycrest works so closely with all of the organizations in the United States, and we can partner, you can sort of get something that's tested and into the market in North America easier, sort of slipping in through Canada to some extent. So that's always terrific. And we have a number of partner organizations across the country in Canada and internationally that are willing and able to adopt these kinds of solutions. And in fact, right now we have a new program called Discover and Adopt. Or what we've done is we've looked at which are the organizations across the country that have the best record for doing this kind of validation work and adopting new kinds of systems and approaches into their workflow. And we worked with them to say, what are the problems that you're facing? And then in the Discover and Adopt program, it's a pull, we would say, as opposed to a push, where a push would be, we've got a solution and we say, who wants to use it? In the pull, it's what are the problems that the long-term care homes or seniors care organizations are facing, and then help them find solutions that they can then adopt and test. And so we're in the middle of that program right now. We've just, it's our first time running this program, and we have 6 of these organizations across the country who are part of this pilot program. So we know that they will be able to adopt these new solutions, and then the goal is to have them work with other, perhaps smaller organizations that don't have the capacity for this kind of initial research, validation testing, so that they can then spread the knowledge of how you can adapt these things. So it's sort of a hub and spoke model is the approach that we're taking. And we also do work with organizations quite closely to help them learn what does it take to be able to adopt new solutions and to stay ahead of what those solutions are.
I see. That's a very large and co-learning circle, right? I guess it has been so that you can like making the system better. And I think and thank you for your answers, and thank you for your presentation as well. And we look forward to meeting you hopefully personally in the GIES Expo one day in Hong Kong.
Sure. And anytime any of you are in Canada, give us a shout. We're happy to show people around and introduce you to whoever you'd like to meet. And we look forward to seeing you in Hong Kong as well.
That would be good. Thank you very much. And we will look forward to learning from you all very soon. Thank you. Thank you, Allison.
Thank you.
Hello, my name is Tanya Petrovich. I'm the Business Innovation Manager at Dementia Australia. So today I'm going to share with you some of the learning tools that we have created at Dementia Australia, specifically for improving dementia practice, and in so doing, improving the lives of people living with dementia. But first of all, let me tell you a little bit about Dementia Australia. So Dementia Australia is the peak body that represents people living with dementia in Australia, which is almost 500,000 people, their family carers, and the people who care for them. Now, most of our work is advocacy work, but we also have 2 service arms, which is client services and our Centre for Dementia Learning. Client services provides support for the person living with dementia and their family through information, education, counselling services. The Centre for Dementia Learning provides education for people who work in the sector, so aged care workers, support workers, anyone who provides support for a person living with dementia. So today what I'm going to tell you about are the tools that we use in educating the support workers and the aged care workers. Now, Dementia Australia has been providing education for over 30 years. And we did that in the traditional format, as you see on the screen at the moment, in a classroom with a facilitator leading a workshop with a PowerPoint and running group discussions and sharing people's understanding of dementia. In 2013, we decided that the impact of that education was not enough to get change happening in aged care services. We wanted to improve the way that we delivered our service so that they would improve dementia care practice. And we decided that what we needed to do was more experiential learning. So giving people an experience so that they could learn from that experience and then take that to change the way that they delivered care. Now, the first thing that we did was back in 2014, we released this, the virtual dementia experience. And it was in Parkville in Victoria. It was a virtual experience before headsets were widely available. And you walk through a house as if you have dementia and experience the house as if you have dementia. So if you come to 2 doors that are exactly the same, which of those doors is the bathroom door? In this virtual experience, every time you pick a door, it doesn't matter which one, it was the wrong door. but the second door would be the bathroom door. It gave people an understanding of what it might be like to live with dementia and live in residence where there are lots of doors and you need to find your bedroom door or you need to find the bathroom. How confusing is it if you don't have a good memory? And so from that experience, we found people really started to understand better the impact of dementia on the person living with dementia. We got lots of great feedback, people telling us how they were changing their practice because of the experience. We also won a lot of awards for that experience, which was really a great encouragement for us to continue to look at virtual reality and how we could use it to further our education. We won a number of awards in Australia and in the Asia Pacific, and also the group of students from Swinburne University who are down there in the bottom left bubble, they won the Microsoft Imagine Cup in Australia, in the Asia Pacific, and also in the USA. And so it was wonderful to see our technology being acknowledged for being a very useful educational tool. But the only drawback was that it was located in Victoria. So if we wanted to get to other people in Australia, it was not possible unless we were going to invest large amounts of money to create more centres like that. So luckily, the technology changed and headsets started to appear in 2015-16. And so we decided to take the experience and put it on a headset. And this then took us to what we now call EDI, which stands for Educational Dementia Immersive Experience. But EDI is also the person that you become when you put the headset on and you experience Eddie's world. You walk through a home as if you have dementia and you're looking for the bathroom. And we've found, again, this experience probably even more immersive than the virtual experience that we did back in 2014 in Parkville. And we've done a lot of evaluation of that, and it's shown that people's knowledge and attitude increases, their empathy increases for the person, and their understanding of care needs increases. Exactly what we need if we want people to change the way that they deliver care practice. So we have some great testimonials that encouraged us to keep going down this track. And I think the wonderful thing about EDI is that it's now going global, in that there are a number of countries who are now using that virtual reality experience. So it's available in Canada, the Czech Republic, Germany, Austria, Switzerland, Singapore, and New Zealand. And there are other countries looking at taking EDI on as well. So really encouraging to see that others think, as we do, that virtual reality is a very powerful tool for teaching dementia care practice. Now, we were encouraged by people to continue our work and maybe expand what we were doing with that EDI experience, and maybe have EDI doing other things and experiencing other things. We decided that that wasn't the way that we wanted to go, because we didn't think that we would get a more significant impact by doing different scenarios. Instead, we felt that we should introduce avatars to the experience. So the next development was what we call a day in the life mealtime. Now, this is set in a residential aged care setting, and we have Ted and Priya in a residential care at dinner time. Priya is the aged care worker providing care to Ted, and Ted is the person living with dementia. Now, when you have the experience, you have it twice. The first time you experience it as Priya, the aged care worker. The second time you experience it as Ted, the person living with dementia. And that's a very different experience. So I can't give you the virtual experience, but what I can do is show you in 2 dimensions what that virtual experience looks like. So I'll show you.
Oh, good. At least Ted's here. About 20 minutes early, but it's fine. Oh, good. You're already awake. Ted and Mary.
Priya, Ted's a feed.
Yeah, Sure. No worries. Okay. It smells good. Looks like chicken. Again. Here we go. Ted? Oh. Can someone get the blinds? Lights right in your eyes. Here we go. Ted, I want you to have a go. It's all set. Okay.
Where are you off to?
Ted, just not interested today, are you? Ted, I've just got to finish up. Give me a moment and then I'll take you back to your room, okay? All right. Have another go.
All right.
Is Ted all finished up with his dinner?
Yeah. Yeah, I think he's done. You can take his plate away.
So that experience we found was really profound in getting people to understand, whilst they as the care worker are trying to do their job as best as possible, for the person living with dementia, that lands quite differently. And the headset experience, you know, putting yourself in the shoes of the care worker and then putting yourself in the shoes of Ted really gets people to understand, wow, when I do that activity, such as look at my phone or are distracted by other conversations, that impact on Ted is quite significant, and his dining experience is profoundly impacted by that. Then we can have a good conversation about how do we do this better? How do we improve the quality of care that we're delivering? So we found the day in the life was a really great way to teach people about how we deliver care. The next development was to take all of this a step further, if you like. So in 2021, we released what we call Talk with Ted. So we took our character Ted, the virtual or the avatar who's living with dementia, and we brought him to life, if you like. We gave him the ability to show emotion and the ability to have a conversation with you. So you can see on the screen there, we have an actor who is being motion captured, and that is being translated into our character Ted. So Ted now is able to show emotions, you know, happy, frustrated, angry, sad. And this now means that when you're having an interaction with Ted, he can respond as the person with dementia might. And I must say, we did this work with Deakin University. Now, the next aspect was that we used machine learning or artificial intelligence to give Ted the ability to have a conversation with you. And the scenario was that Ted is sitting on his bed in his room, in his pajamas, and you as the care worker enter the room. Now, your purpose is to get Ted to agree to having a shower. And the reason that we chose this particular scenario is because bathing, we know in aged care, is a significant issue, as many people find it challenging. So that's the challenge. And what we do is we ask the individuals to remember what a good skills in providing or connecting with a person in a conversation are. And so there are 5, if you like, hurdles that the person has to achieve in their interaction with TED. The first one is you must use TED's name, which is simple. The second one is you have got to introduce yourself and give TED an orientation as to who you are. The third one is listening to clues and emotional cues that TED is giving you. And I think this is probably the area that people usually stumble. So when TED is telling you something that's not what you expect, make sure that you engage with him and actually tap into what TED is feeling and his story, which is number 4, acknowledging his personhood. And then finally, we get to the point where we can ask TED, would he like a shower or not? What you find is that people go through this scenario twice. And on the first scenario, they either take a very long time before they get TED to agree, or they get to a point where TED is so angry he won't interact with them anymore. So it's a really powerful tool to put into practice your communication skills and see whether you can get TED to agree to the shower. At the end of the scenarios, you get a conversation report telling you where you did well or where you didn't do well. And then obviously that's the end of the session. But what we did was we ran a trial with aged care workers, and we took just 30 of them, so a small number. We put 15 through the TED experience and 15 through a traditional online learning experience. And then we came back to them 4 weeks later and then again 8 weeks later. And what we were asking is, do people remember the interaction with TED? Do they engage with TED as if he is a real person? And do they actually learn anything from TED? And this is what we found. So what we found was people who engaged with TED, they actually emotionally connected with him. They did treat him as if he was a real person. So there was, if you can see the scores here, they're all at, at the top end of the scale, around the 5. So they were emotionally connected, they engaged with TED, they learnt from TED, and they felt more confident after their interaction with TED. But what really surprised us about this whole thing was, this whole trial, was that the people who did the online learning, traditional online learning, they, after 8 weeks, 80% could not remember anything that they learnt, which was a bit disappointing, and 20% remembered only something. The people who did TED 8 weeks later, 100% could remember what they learnt. And not only that, they actually told us about how they were putting that experience into their practice, into working with people living with dementia. So, which is ultimately what we want. We want people to take the learning and put it into practice. So it was really exciting to see that result. We need to do a larger evaluation, but that initial pilot was just so exciting to us to show that this type of education is a really powerful way to connect with learners and get them to change their practice. I've got a little video to show you TED in practice.
Dementia Australia, along with Deakin University's Applied Artificial Intelligence Institute, are proud to introduce TED. TED is a virtual character that is living with dementia. You can have a conversation with TED and he will respond just like a person with dementia would, showing signs of memory loss, confusion, and a range of emotions. We're really excited to show you the first version of Talking with TED.
G'day, Ted.
It's nice that you are here.
How are you going today?
You haven't even introduced yourself.
My name's Andy. Shall we go and have a shower?
Hello, Andy. Excuse me. What do you do again? I don't just let anyone come in and help me.
To bring TED to life and make the conversation as realistic as possible, we used a range of technologies, such as a speech-to-text engine, a natural language engine, and a text-to-speech engine. We also partnered with Fika Entertainment to use their real-time production pipeline to capture motion data that represents the movement of a person living with dementia. The key aim of this project is to improve the quality of care by teaching carers how to empathise with people living with dementia. Therefore, learning how to build rapport is central to having a positive and productive conversation with TED.
How are you feeling today?
I was awake all night. I was thinking about Patricia.
Who's Patricia?
Patricia is my wife.
The results from this trial suggest that the impact of learning through practice is higher than when compared to traditional methods such as classroom or online learning. We look forward to more carers experiencing talking with TED for themselves in the not-too-distant future.
Thank you for watching. See you next time.
So if you want to find out more about TED, you can go to our website, dementia.com.au, and you will find more information about TED. If you search for TED, it'll come up. Right, so we've had great feedback again on TED, and I encourage you to have a look at it. Finally, I just wanted to mention our Ask Annie app, which is a free downloadable app onto telephones. And again, we worked with Deacon to produce this app, and it's about having short micro-learning, like short 8-minute sessions that you can do at any time, any place on your phone and learn more about dementia. Again, you can go to any of the app stores and you can download it. I'm running out of time, so I won't show you the film. But if you want to know more, you can, as I said, I said .com, dementia.org.au, and you can actually search for any of those items I mentioned. The Talk with TED, Ask Annie, Eddie, they're all on that website. Thank you very much. Thank you for your time.
Thank you, Tanya. We shall now begin to look at the questions from the floor. So the first question is about the Talk with TED project. How long does it take from the idea to the whole production? And in what way to involve people with dementia to help in different stages?
So it took us 3 years to develop that particular application. It was very much more complex than I thought when we started. I thought it was a simple idea. You know, really it's like a chat bot in some respects, but it was much more complex because in having a conversation, obviously the learner can respond in many different ways. Therefore, you need to be able to have the avatar respond to any possible question that's put to it, if you like. In the experience, we really focused on speaking with carers and people living with dementia, and which we have access to, obviously, being Dementia Australia. We have a carer cohort who we can talk to get this information from, and we ask them about their experiences and where the difficulties were, and through that we built a conversation tree, that was really the bit that took the longest, the conversation. Building TED in himself was quite quick, but the conversation behind it, if you like, the machine learning behind it was the difficult part.
I see. Then it takes a very long time in simply collecting data. And so the second question is, do you think what is the most significant change in practice after introducing tech training? Do you think that healthcare professionals should also attend such trainings, or even students of medical school?
Yeah, it was really interesting. What we found was, because we had in our trial people who were managers as well as people who were just new to the industry, it's actually a very effective tool to see who is appropriate to work in the industry. So you could actually use it with students or with people who want to enter the industry to actually see how they respond to TED. And they might find, you know what, this is not for me. I didn't enjoy that experience. Or alternately, they find, wow, that was a challenge, but I think I actually want to do this. I want to support people who are living with dementia and have these difficulties. I found that really challenging but rewarding, getting to the point where Ted said, yes, I'll have a shower. So it really is not limited to people who are early or late in their career. I can see applications at all levels. Interestingly, we used it with some government officials to get them to understand what it's like to care for someone with dementia, because, you know, they're making decisions about where funds should go. It's important that they understand what the challenges are in delivering dementia care. So it's a tool that's incredibly powerful.
So it is not just for training, it's also for education. And there is one more question coming from what is the most difficult part in simulating responses of the character Ted? Any principle behind when creating the character?
Yes, so we built in learning hurdles, if you like. So one of the most important teaching is that we want people to connect to the person, to connect with their story, their life experience. So Ted actually has a very complex life history behind him, and he can talk about his wife, his working career as a teacher. He can talk about his love of gardening. These are all aspects of the person that carers need to understand and need to understand how to connect with. So in working with Ted, the person will fail if they don't connect with his personhood, the things that are important to him. So if the person is so fixated on the task and getting Ted to go to the shower, they will fail. Ted will get very upset and they won't get what they want. But if they understand Ted's personality and start to ask Ted questions about his history, this is what will get them to the point where Ted will trust them and then move forward with them.
I see. That's very funny to like having like an avatar who actually has a life behind it. And one last question is, Ted was taught to talk to rather directly with the observable emotion. What are the professional training objectives other than shown in the slide that you talk about conversation milestones? It seems like a very grumpy person.
Oh. Okay, so the emotions are there so that, and it happens in real life, yeah. Sometimes we go in with the intention of caring for someone and it doesn't go so well and they can get very upset. So it was really important to us that Ted can get very upset so that people learn we can get into the scenario, but you can actually get out of it again. So your conversation with Ted is really important, as is your conversation with anyone. Ensuring that you connect with them, you connect with their personal story, you connect with their emotions. So if you walk in and Ted, for example, might be unhappy and he might tell you, I didn't sleep very well last night, for example. It's important that we focus on that we don't start talking about showering and the task at hand, but that we actually connect with Ted and we say, okay, Ted's not happy, there's something not right. Let me understand that first before we move to the showering. And yes, Ted can get very angry, but this is the reality of what actually happens. That's why we felt that was really important in getting that real life emotions happening in the avatar.
That's very wonderful. And we hope to meet probably Ted one day in our expo very soon. Thank you, Tanya, for your valuable sharing.
Hi, everyone, and thank you for inviting me to give this talk about future scenarios, dementia, and AI. My name is Marianne Barland, and I work as a project director at the Norwegian Board of Technology. The Norwegian Board of Technology is an independent body for technology assessment. This means that we advise the Parliament and government in Norway on the impacts and options of technology. We also have in our mandate that we should use participatory methods and foresight. And the project that I'm presenting to you today is one example of this. When we use scenarios, it's not an attempt to predict the future, but rather to create plausible and knowledge-based stories about the future. It then becomes a very useful tool, not for discussing just one, but several different futures. It can create a greater understanding of change, both technological and societal, and demonstrate that technology is not something that just happens to us. We have choices, and these choices have consequences. The scenarios are developed on the basis of demographics and technological trends, of which we are quite certain. And they have a time horizon of about 10 years into the future. This makes it far enough into the future so that we can predict change, but at the same time not too far and into the land of science fiction. In this specific project, we wanted to focus on an issue in the Norwegian society, the increasing number of people being affected by dementia. Today, around 100,000 people are diagnosed with dementia, and we see that doubling towards 2040. And at the same time, over 400,000 is affected by being next of kin. And this development, in combination with fewer hands and fewer people working in the health and care sector, and the increasing pressure on public resources, makes it an area where new ideas and solutions are very welcome. There are several technology trends and developments that can be relevant in dementia care. Smart houses and wearables are one area, because we see that the development in sensor technology keeps making sensors are both smaller and much more powerful than before. This means that medical sensors can be used at home and be administered by the patient themselves. Measurements can be taken automatically or with the help of a smartphone and a tablet, and sent to medical personnel who monitors development and intervenes if something irregular happens. Sensor technology can also be used in the surroundings. GPS is one example. It can be used as a safety measure if a patient walks out the door or gets lost. There also exists, for example, fall detectors that can be used at home if a patient has an accident and is not able to get up by themselves. In addition, artificial intelligence becomes more widespread, also in technical solutions for the elderly. Digital assistant like the iPhone Siri or Amazon's Alexa can be of great support, for example, connected to calendar or daily reminders. For example, when you have to take medication regularly. The fact that the user interface is speech lowers the threshold for users not accustomed to taking up new technology. Also, robots can be assist both the patients and the care worker, for example, in heavy lifting, getting up and down from a bed or a chair, or in the bathroom for personal hygiene. Algorithms and data can be used to find unexpected patterns, for example, in diagnosing dementia. There are already studies done where machine learning algorithms detect dementia several years earlier than with traditional methods, only using routine data collected by the GP. There are also many possibilities connected to digital simulation, and it can be done in several different ways. We have virtual reality, where one wears glasses like these and moves inside another reality altogether. Augmented reality, on the other hand, is where information and graphic is presented on top of our regular world through a camera, for example. Popularly seen in the game Pokemon Go a couple of years ago. And there are several opportunities related to this. Some are connected to entertainment, games, and exercises. In the first picture here, I am testing an exercise program for stroke patients. It's a game where the goal is to catch butterflies, but it's designed in a way so that you move your hands in a specific patterns to retrain your body after the stroke. Artificial intelligence can also be used as a help to identify things or even persons by using the camera on a phone or a tablet. Simulation can also be helpful for training of health workers and volunteers, because you will be able to simulate the kind of situations that you might come up in reality when you are doing your work later on. In addition to demographics and technological trends that we are quite certain will happen, there will always be uncertainties related to the future. What political choices are being made will also have impact. And when developing the axis for our scenarios, we try to identify questions that are connected to uncertainties and that we think will have a big impact, no matter what the political choices being made are. And in these scenarios that I will show you in a minute, we have chosen to look at two uncertainties. One is connected to organization of service, whether we will have large public service models that focus on professionalized services, or a model where the public functions more as a platform and we have next of kin and volunteers to perform the actual care services. The other questions relates to the value of autonomy and control of the disease. And the solution and the reality will always be somewhere between these extremes. However, when we make scenarios, we want to push the concepts quite far in order for the scenarios to spur discussion and engagement. And here you can see the two axes that forms the basis of our scenarios. One displaying the organization of services. Is it professionals or volunteers who will be in charge? And horizontally, we play out the difference between emphasizing control versus autonomy. After identifying these axes and questions, we developed three different kinds of scenarios. And all the scenarios have something positive and something negative to them. They should not be designed as one good, one bad, and one neutral. And in addition to a description of what society would be like in each one, we also write personal stories, showcasing who will benefit in different settings, what ethical and moral dilemmas that might arise, and what the role of government, citizens, private companies and NGOs should be in each of these. And I will give you a short walkthrough of each scenario. Scenario one describes a society where the pressure on health and care services have forced a reorganization and redistribution of responsibility. Next of kin becomes responsible for care, and the municipalities have taken on role more as a coordinator of these services. To reward this new responsibility, relatives and volunteers receive compensation from the state and access to a support group and training courses. In order to have a functioning health service, the GP is replaced by a digital first line, and everyone gets a personal digital assistant. Sensor technology is being installed at home, and medical issues are surveyed through sensors and wearable technology, where a doctor assesses the data and medical personnel takes action if the data shows that a condition worsens or a new diagnosis is discovered. For the elderly themselves and the patients, this scenario might feel safe. They are looked after by people they know. It's the same people every week, and they get a doctor's attention when it's necessary. At the same time, not all relatives want to take on this kind of role, and the increased use of digital tools and data analysis might feel overwhelming for some people. The second scenario, autonomy and participation in one's own life, is of the highest importance. The many digitalization processes have met resistance, and politicians have implemented a principle where one has a right to say no, both to being measured and analyzed through sensors and AI, and a right to meaningful human contact instead of being set up with a robot for social and emotional support. To ensure autonomy and participation, everyone over the age of 75 creates aging plans where they describe what they want and what they do not want for their future. Many municipalities are built-in generation villages where seniors, students, and families live together. They are encouraged to help each other and engage in volunteer work connected to grocery shopping, babysitting, and social activities. And this kind of volunteer work is coordinated through time banks. In this scenario, autonomy and participation is valued, and that is a good thing for most people. But focus on this can also create confusion and some bureaucracy. If, for example, one does not want to use technology that collects health data, it can take a longer time to get help with specific issues, and in some cases, difficulties in identifying a worsening condition. The third scenario describes a reliance on professional workers to provide care services and national oversight by the state. After seeing huge variation in how different municipalities use technology in health and care services, the state have taken over the responsibility. The municipalities can choose technology from 3 pre-selected providers, and their use of resources are monitored. The goal is that all citizens get the same service and the same quality of service, no matter where they live in the country. A national screening program is developed, and everyone over the age of 65 is encouraged to participate. The results are used to plan ahead, and predictive algorithms are used to measure if someone's condition is worsening. Speech-controlled digital assistants help seniors in their everyday life, for example, by giving reminders, daily medication, or events in the calendar. It also collects data from smart home technology and wearable sensors. The data is used by nurses and doctors to give personalized care and treatments. This creates a nation that is well set up for research and development in this area because of the large databases of health data collected through these screening programs. On the other hand, not everyone likes being monitored all the time, and the screening program can provide information about future diagnoses that one does not necessarily want to know. They just want to live in the moment and not know that in a couple of years you might develop a disease. The scenarios are created by an expert group together with us at the Norwegian Board of Technology. But we always want to discuss these issues in a broader context. And we always invite a larger group of stakeholders to participate in a scenario workshop. And the goal here is to discuss these issues in a broader context and that the participants use their own knowledge and experience to create future visions and also policy recommendations related to this that we later on will communicate to politicians both at the parliament and in our government. The discussions in this project were very productive, partly because the scenarios are a good tool to kick off discussions, but also because the participants meet other people working on the same issue as themselves, but from different backgrounds that they don't meet in their everyday work. This workshop brought on discussions on several topics, such as what role family and volunteers could or should have in dementia care, how the use of technology can be coordinated, if it should be a national responsibility, or if every municipality should do this individually, how data can be shared while the privacy of both patients and other family members are respected. They also discussed how the integrity and involvement of patient can happen both before and after a diagnosis, and also if there should be a right to resist the use of technology, and if so, how this can be done without creating an A or B level of patients and care services. In summary, I would like to repeat 2 success factors that we believe made a project like this useful for our politicians. One is the creation of scenarios that spurs curiosity, engagement, and both negative and positive feelings. This requires a solid overview of technology trends, but also creative and playful thinking in order to make the scenarios that bring forth some emotions to the readers. The other success factor is to engage stakeholders in discussion about these topics. There will always be actors that are affected positively or negatively by technological development and policy decisions. But often actors that have stakes are not automatically consulted or included in decision-making processes, even though they are the ones that have to live with the consequences of these decisions. So, solid stakeholder involvement can lead to better informed policy decisions and more critical discussions about the topic at hand. Involving a broader and more balanced group of actors make the process more diverse and enable more resilient solutions. Also, when the concerned actors are included in the process, it can lead to easier implementation of policy decisions and technology implementations, as the involvement gives stronger ownership among the actors. So with that, I would like to thank you for your attention. Due to the time difference between our countries, I will not be able to participate in the Q&A, unfortunately, but feel free to send me an email with any questions you might have, and reports from this project is also available on our website. Thank you very much.
咁多位大家好啦，咁多位早晨，我叫 Kenny， 我係賽馬會耆智園嘅副總經理，咁大家都可以叫我 Kenny 就得噶啦。咁啊，好，首先多謝咧香港特別行政區同埋香港社會服務聯會嘅邀請啦，喺今次樂齡科技博覽暨高峰會入邊咧，俾我有個機會可以同大家分享一下頭先3位嘅即係世界唔同各地嘅一個即係專家喺度發展緊嘅一啲關於腦退化症或者認知障礙症嘅服務。咁我哋作為一個本地嘅一啲學習嘅即係嘅 practitioner 啦，或者係一啲嘅專業嘅同事咧，其實我哋都有諗緊其實腦退化症係回應住呢個題目，點樣去提升佢嘅生活質素，亦都睇翻3位唔同嘅專家講嘅嘢咧，我可以嘗試下用一個叫做 micro、micro 同埋一個 macro 嘅層面去睇。因為3位唔同嘅專家，首先可能第一位啦，即係 Dr. Allison 咧，其實佢喺一個 micro 嘅層面話翻俾我哋聽，我哋個服務提供點樣到位嘅，即係話如果一個腦退化症嘅朋友同埋佢個屋企人，佢哋有一個旅程，我哋叫 Dementia Care Journey， 喺成個旅程入邊，佢可能由懷疑自己有腦退化，到去想揾診斷，到去診斷後支援服務，到去真係要有一啲嘅社區照顧、日間中心、院舍服務，以至到香港其實近年亦都提嘅一啲 palliative care， 其實喺香港嗰個即係模式喺個 micro service 上邊咧，我哋可以提供到幾到位嘅服務。喺加拿大咧，我相信咧佢哋咧就係好人本啊，佢哋可以嘗試透過喺你唔同嘅需要，我會設計唔同嘅房間俾你啦，會設計唔同嘅服務模式俾你啦，甚至乎咧佢提到一樣嘢，我諗香港未來咧係一個幾重要嘅部分，就係一啲叫遙距嘅 assessment， 即係話譬如佢哋都有提到話會唔會係個屋企人咧可以攞住一個 camera， 然之後咧佢去 scan 成個大約嘅屋企係點，大家都明白啦，香港嘅屋企有幾大啦。家居可以去到好大，即係可以係好多唔同嘅設計，亦可以去到好似我哋嘅公屋，雖然一個好細小嘅單位，但係五臟俱全嘅時候，點樣可以喺個環境上咧提供到一啲譬如叫腦退化症嘅友善嘅設計啦 ，dementia friendly environment， 或者譬如喺一個建築上，我哋喺設計我哋嘅 屋企或者家居嘅時候，點樣因應住腦退化症嘅一啲嘅需要而去設計咧？譬如佢哋個光線盡量用啲唔反光嘅顏色啊，點樣可以喺嗰個窗簾嗰度用一啲比較唔係密集嘅 pattern 啊？點樣用翻一啲顏色嘅對比啊？我相信咧，頭先 Dr. Allison 咧有提到一啲即係好細微而又好人本tailor-made 嘅 service 俾我哋去即係了解。咁所以咧，作為一個本地嘅一個即係 practitioner 去學習 from Dr. Allison 嘅時候咧，我哋會發覺，如果我哋可以將我哋嘅 assessment 以往嘅 face to face 然之後多一個選擇，嗱我哋從來都唔抗拒 face to face 啊，亦都係好嘅。但係同時間 make one more option 可以嘅話咧，如果喺啲遙距，譬如我哋可唔可以用 Zoom 做 MOCA 咧？我哋做一啲所謂認知測試，其實係咪可以用一啲遙距嘅方式？甚至乎，譬如我哋香港中文大學同埋耆智園都研發咗一個叫做中大網上認知測試嘅 Apps， 佢可以透過平板電腦去喺家居入邊咧做一啲嘅即係認知測試，然之後係需要跟進嘅話，我哋先至去揾即係唔同嘅專業同事去 follow up。其實喺家居嘅支援咧，我哋好多時都要諗下。以往除咗係一啲上門嘅服務之外，譬如一個遙距嘅評估，一個遙距嘅認知嘅測試嘅評估，甚至乎佢亦都有提到，譬如一啲 e-visit 啦，即係譬如可唔可以喺家居上邊會 match with 一啲義工，或者 match with 一啲同事，定時定候咁樣去提供一啲網上嘅探訪等等。咁呢一個咧，我相信無論 COVID 係唔係一個好大嘅影響都好啦，對我哋未來嘅服務咧，都係有需要去研發呢一個方面啦。因為好多腦退化症嘅朋友，或者係啲即係老人家，其實佢可能係即係輪候緊一個長期服務嘅時候，佢係需要好多家居支援，而佢哋開始體弱，未必去到中心，或者未必可以 travel 到去一個特定嘅地方嘅時候，我哋可以提供啲咩 service 咧？咁呢一個咧係喺 Dr. Allison 咧提我哋嘅一樣嘢，點樣可以喺 end user engagement， 就係話。譬如我哋喺耆智園咧都有一啲研究，就係個腦退化症嘅朋友，佢哋嘅 voice 係點啦，佢哋點樣 feedback 我哋嘅服務啦，甚至乎佢可以用一啲乜嘢嘅，即係譬如 feedback 嘅一啲user form 啊，或者用一啲即係可能咧俾一啲唔同嘅意見，俾我哋去設計一啲即係遙距嘅服務。呢一個部分，我相信喺 micro practice 喺一啲前線嘅即係服務嘅提供嘅時候，可以俾我哋本地嘅一啲 practitioner 一啲參考啦。去到第二部分啦，即係 Dr. Tanya 咧，其實佢喺澳洲 Dementia Australia 咧係一個好出名做 training 嘅地方嚟嘅。咁佢亦都係其中一個即係地方咧，就提倡呢個叫 Dementia Friendly Language 啦，即係咩叫友善言辭啊？譬如我哋稱呼做腦退化症人士啊，我哋將行為問題會稱呼為行為表現啊，或者受壓下嘅行為啊，或者我哋會講照顧者嘅影響啊，多過照顧者嘅壓力啊。其實佢喺 miso 嘅層面喺度。cultivate 即係我哋話好似耕種緊一種我哋叫做以人為本嘅文化，所以咧其實我哋咧做腦退化症嘅服務，當年我諗我初即係畢業嘅時候已經做緊一啲即係認知障礙症或者腦退化嘅培訓嘅，時至到今日2022年，其實我哋個培訓可以點樣行前一步咧？其實我哋唔係講緊淨係 knowledge 同 skills 嘅一個 issue， 即係唔係淨係知識同埋技巧嘅問題，其實最緊要就係個 attitude 嘅問題。所以咧，我哋喺即係我哋嘅機構服務嘅上邊咧，我哋有一個 model 叫 ASK，即係 A 咧就代表 attitude，S 係代表 skill，K 係代表 knowledge。我哋點樣將呢三方面咧去融合擺落去做 training 度？所以咧，你會見到喺 Dementia Australia Tanya 咧，佢哋用一個好即係 innovative 嘅諗法，就係我可唔可以用阿凡達啦，即係用阿 TED， 我用一個模擬嘅腦退化症人士，可以即時俾一啲互動，譬如。如果嗰個照顧員，譬如 PCW 或者 HW 嘅同事，佢哋可能咧做啱一啲方法，我就會有一個微笑啊，或者我哋會 go ahead 係佢可以繼續好順利去 complete 佢嘅 task。但係咧，如果佢可能咧有少少嘢相對地冇咁理想，或者甚至乎有時可能大聲咗咁樣，佢可以透過你個 voice 嘅 detection。可以透過你講嘢嘅速度，如果可以進一步再去 tune 嘅話咧，我相信譬如Dr. Tanya 喺 Dementia Australia 嗰邊咧，其實喺度不斷 modify 緊一個 AI learning 嘅，即係話如果我哋第時要做一個訓練教材，本地其實都有一啲類似嘅一啲我哋叫 virtual experience， 但係同時間咧，我哋就要諗下嗰個內容係點啦，個 debriefing 係點啦，因為本身我研究多少少就係腦退化症嘅朋友嘅主觀世界，同埋佢點樣去理解身邊嘅事物啦，佢哋個 mechanism 係點啦，佢哋個機制點樣去 interpret 呢個世界咧？其實呢一度咧好多時都唔係即係我本身有啲乜嘢去認識嘅，其實係聽好多唔同 嘅腦退化症人士嘅一啲自傳啊，睇佢哋嘅寫嘅嘢啊，甚至乎佢哋錄嘅 video 咧，去得出一啲嘅 findings。所以咧，我諗咧，其實喺 Dementia Australia 入邊咧，對我哋本地嘅一啲嘅即係 insight 或者 implication 咧，其實就係講緊我哋做培訓，當知識同埋技巧係一啲 foundation 嘅時候，我哋點樣落去下一步，令到即係一個專職同事，譬如社工、護士、職業治療師、物理治療師或者其他治療師。同埋一啲非專職嘅培訓，可能係一啲前線護理員啊，即係一啲唔同嘅即係家居護理員等等咧。其實佢哋點樣去有啲唔同嘅學習模式啊？因為我相信咧，大家即係如果做培訓啊，大家都會好清楚。其實如果你同前線嘅同事去做一個培訓，同埋一啲專職嘅同事做培訓咧，佢哋嗰個焦點可能唔一樣嘅。咁如果透過呢一個Dementia Australia 講嘅一種模擬嘅狀況，可以咧去體驗同埋感受其實腦退化症嘅世界係點啦，甚至乎佢可以即時俾翻一個 feedback，令到嗰個學習對象咧係可以有一啲多啲嘅記憶。其實因為呢啲係情感上嘅記憶。我哋研究腦退化嘅時候，亦都發覺情感記憶其實係好緊要嘅喎。即係當你一個人咧帶住一啲嘅情緒，甚至乎你親歷其境，或者我哋叫做在境學習啦 （contextual learning） 嘅時候咧，你會記得好啲嘅。咁以往喺香港，我哋喺其實又點做咧？就係我自己或者我哋培訓嘅同事去扮演腦退化症嘅朋友，同佢哋互動，增加佢哋咧臨場嘅感覺。但係如果我哋可以未來係用一個即係virtual 嘅。即係用一個可能阿凡達咁樣嘅情況咧，咁我覺得咧都係一個可以喺唔同嘅機構，佢哋自己可以無時無刻，或者係一啲佢哋適當嘅時間去做一啲培訓。香港最大嘅困難就係好難同一時間揾到一班同事去上堂，大家都好明白啦。同時間咧喺嗰個program 入邊有一啲叫 conversation report 啦，嗰個都好緊要嘅，就係提醒翻參與呢一次嘅活動嘅同事咧，其實有啲咩做得好，有咩做得唔好，呢個 reflection 同 feedback 咧，我相信係未來喺本地嘅培訓咧係需要去大家留意嘅。咁啊，最後啦，其實咧從 MISO 之後啦，即係一個我哋叫做喺個 peer service 或者喺一啲提供服務者嘅服務培訓之後咧，去到咧Dr. Marianne 啦，佢會講到一個 policy 嘅層面，我覺得係一個 macro level 啦。即係如果喺提升佢哋嘅生活質素，除咗喺 micro 做好我哋嘅服務嘅設計，喺 meso 做好我哋嘅培訓同人手嘅介入，政府嘅政策其實都重要嘅。佢講一個好重要嘅點啦，其實我哋香港咧都有一啲同事喺度做緊嘅，就係點樣透過唔同嘅持份者去俾 feedback， 然之後無論係喺服務提供者、政府，甚至乎係警隊，甚至乎係房屋設計，以至乎係監務委員會。其實佢哋咧有唔同嘅持份者咧，點樣可以咧俾一啲嘅意見，令到喺腦退化症嘅朋友，如果佢喺社區度盡量留到喺社區嘅居住係十分好啦。但係如果佢係真係入到院舍嘅時候，亦都有一啲相關嘅服務配套。所以咧喺個政策層面咧，其實都係要去了解，譬如未來個方向，我哋香港係面對緊高教育水平嘅老人家，開始咧可能咧仔女嘅支援比較少啲，點樣可以咧去 detect 得好啲即係腦退化症，或者可以 make 多啲嘅唔同嘅診斷，然之後有支援服務啦。喺人手上點樣可以透過佢哋，譬如用義工動員咧一啲叫時間銀行啊，或者咧一啲唔同嘅人咧去，譬如做一個上門嘅 respite， 咁亦都可唔可以喺個政策上去推行，去舒緩到護老者嘅一啲嘅狀況咧？近年講嘅喘息服務都係講緊點樣俾護老者唞下，所以呢個咧喺政策上咧可以參考翻，即係喺挪威嘅一啲嘅方向政策，其實佢係透過唔同嘅持份者，甚至乎腦退化症人士加埋嗰個護老者都可以參與一個意見嘅即係分享咧，其實呢個係重要嘅。最後係講緊一種演算法啦，即係話可唔可以有一啲嘅方向去 predict 未來？其實我哋創委會耆智園都希望咧，我哋嚟緊咧去研發一啲關於行為嘅 prediction。因為咧腦退化症嘅朋友最難處理，其中一樣嘢就係啲行為啦，或者一啲改變咗嘅行為。如果我哋有一天可以透過一啲嘅科技去了解到點樣去預測佢可能開始會有一啲坐立不安啊，佢開始有一啲攻擊行為啊，佢開始有一啲唔同嘅行為出嚟嘅時候，我哋喺呢啲行為之前介入，而令到佢減少呢啲咁樣嘅即係所謂比較困擾嘅行為嘅話咧，我哋可唔可以提供一啲更加好、更加優質嘅服務俾我哋腦退化症人士咧？所以我希望咧今日呢個時間雖然短短地啦，但係我哋從 micro Macro 呢個層面，可以由3位講者睇得到點樣對我哋本地嘅一啲 practitioner 嘅一啲嘅 insights 或者 implication。如果大家可以有機會咧再交流多啲，我好希望我哋創馬會耆智園咧可以同大家多啲分享，同埋咧了解下我哋嘅服務。咁好多謝大家今日去即係聽我講嘅一啲分享，我希望我講嘅嘢可以幫到大家，多謝各位。